Next, we have Dr. Steffen, who is going to talk about impending optic neuropathy.
All right, good afternoon, everyone. This session is about unforgettable neuro-ophthalmic cases. I don't think this is an unforgettable case, but the lesson is unforgettable. Okay, so this is a 63-year-old gentleman referred from his own eye doctor with a suspicion of arteritic anterior ischemic optic neuropathy. He has some known arterial hypertension, some hypercholesterolemia, and type 2 diabetes. He's been treated for all three of them, and he's been screened yearly for his diabetic retinopathy. He just returned from Switzerland a few weeks ago. He travels very often to Switzerland from Denmark for business purposes. He noticed some reading difficulties about 2 weeks ago, and the week before, when occluding his left eye, he noticed very blurred vision on his right eye. He has no symptoms suggestive of giant cell arteritis. On exam, he has a very poor visual acuity on his right eye, where he also has a relative afferent pupillary defect. He has completely normal lab values. So this is how it looks like to start with, and you see here on the right side he has disc edema, on the left side he has a very, very tight disc. This is the OCT, and you see a lot of fluid extending into the macula on the right side. There's a little pseudo hole here on the left side. So the tentative diagnosis is either it's NAION, or it could be neuroretinitis because of all this fluid in the macula. 3 weeks later, he comes at his second visit. At that time, he had had an MRI, which was completely normal. The vision has gone up to 6/12 on the right eye, and the left side is still normal. So this is how it looks like at this time. And this is the OCT, which confirms that the RNFL is increased. On the left side is normal. So these are the visual fields, pretty dense scotoma, most pronounced inferiorly on the right side, and a little on the left side also, but not so much. So the fluid is not that extensive here at 3 weeks. There are some exudates, and so we say that, well, it was probably an iron, and he should come back again in 1 month. He comes back 1 month. At this time, he experiences a gradual visual improvement. He says he just returned from Switzerland another time. And this is how it looks like. Now the RNFL is down to 94 here. And if you look on the left side and remember how it was, of course the visual fields are pretty much the same, but if you look on the left side, this is the interesting part here. He has no problems on the left side, but actually there is a little fluid now extending into the macula on the left side, and also the RNFL has gone up from 90 something, 94 I believe it was, to 106 on his asymptomatic fellow eye. Okay, so he comes back on the 4th visit. It's 3 months now, and he experiences visual worsening, especially when reading, and he experiences blurred on the left side. On the visual acuity is good here. He just came back from Switzerland once more, and he's been flying. He says he's been flying to Switzerland 6 or 7 times for the past 6 months. So this is how it looks like now. Of course, there's now atrophy on the right side, and on the left side, there's clearly disc edema and RNFL swelling, so he has a left NAION with a central scotoma here on the left side. Here you see there's much more fluid extending into the macula also on the left side. So he has a left eye as well. And on the 5th visit, the vision is now stable, he's healthy, he hasn't been flying, and now he's starting to getting some atrophy on the left side as well. All right, so if we plot the RNFL thickness of the second eye over time. So we saw him, this was his 2nd visit, 3rd visit, 4th visit, fifth visit and final visit, and here are the RNFL on the y-axis. And of course, when he had his NION on the left eye, he had a steep increase in RNFL. But what is the teaching point here is that actually he had an RNFL increase also between the second visit and the third visit, asymptomatic. So this is a case of a bilateral sequential NION in a middle-aged frequent flying man, each event occurring after flying. And this asymptomatic RNFL increase on the second eye after flying, he had before the second event occurred. So this is actually a thing, the flight-induced NION, or as I like to call it, fly-on. I've actually gone back and looked at the few cases we've had, and some of them we've actually seen just as a regular follow-up on the first eye, and it's very, very typical that there is this incipient RNFL increase on the fellow eye just before getting the proper NION. So what could be the explanation for this? Well, flying actually affects your blood oxygen saturation levels due to the reduced air pressure and lower oxygen availability in airplane cabins. And commercial aircraft cabins, they are usually pressurized, simulating altitudes of about 1,800 to 2,400 meters. But at these altitudes, the partial pressure of oxygen is lower than at sea level, which can lead to a decrease in the oxygen saturation. For most people, this is no problem. We see in all people saturation goes down to about 93 or 94%, but it can be a problem if you have a very, very tight disc to start with. There is one study which is actually quite nice, where they studied the pressure within airplane cabins. And what was interesting in this study was that actually the wider airplanes or the newer models, they have a lower cabin pressure than the narrow airplanes. So actually it's contradictory to what most people think. It can be better flying long distance than short distance, because in short distance it's the narrow airplanes. The least likely clinical explanation, which has also been introduced, was that if this was due to a thromboembolic event. The problem with this explanation is if you should suspect a deep vein thrombosis to embolize, then the thrombus must pass through a right-to-left shunt, such as a persistent foramen ovale, to enter the arterial circulation, and this is pretty unlikely. An interesting theory, now it's the second time we hear about it, Professor Sadun today, it's because at Harvard they've done some studies on mice at different oxygen levels, and they find some very significant changes in the metabolism and the mitochondrial function at these higher altitudes. And based on that, Professor Sadun has come up with this theory that when the ATP production goes down, the retinal ganglion cell axons compensate by upregulating their mitochondria, and this in turn constipates the axons. So perhaps the appearance of the RNFL swelling in the pre-symptomatic stage of LHON can actually be a trigger for the event to happen. This is in LHON, but this could also be taking place in NION. So the swollen axons, more than the ischemic ones, might trigger the AION. So take-home message from this is you can fly on because there are millions of people flying all the time. Shouldn't be afraid of flying, but it could be possible that the lowering of the blood oxygen saturation in a susceptible individual with a tight disc with a very low cup to disc ratio, with an incipient NION with an RNFL increase, which is asymptomatic, plus or minus vascular coexisting conditions. This could be a trigger for hypoxemia and pose a risk of NION. So if someone has a history of a unilateral NION coupled with other underlying vascular insufficiencies and a disc at risk, it might be wise to wait flying until there's no more disc edema. Usually I say 2 months. So beware of the second NION and look for asymptomatic RNFL increase. The question, should we have a possibility of supplemental oxygen? This is always a matter of discussion. I know that it has been possible for some patients to request it on some flights, but that really depends on the airline. All right, so fly on, or I want to say fly on. Thank you.
Thank you, Professor Steffen.